In the current study presented at ASH 2020, I give the final results from a single-arm phase 2 trial for newly diagnosed multiple myeloma patients treated with the 4-drug combination of carfilzomib, lenalidomide, dexamethasone, and daratumumab. The carfilzomib drug was given on a weekly schedule with 56 milligram per meter square, so weekly wKRd-D dara if you want. The study has enrolled a total of 41 patients per the study protocol. Patients have received a total of 8 cycles of combination therapy. The study had traditional inclusion criteria with labs and performance status and so forth. Because the study includes 8 cycles of this combination therapy, and then the study is over with the primary endpoint set as MRD negativity. Therefore, there is no exclusion if patients choose to not go for a bone marrow transplant, or if they're not even a candidate for bone marrow transplant. As long as they are eligible to go on the trial, they could go on the trial. So patients who are slightly older could go on if they have a good performance status and good lab results. For patients who are fit and potential candidates for a transplant, they would be advised to collect stem cells after 4 to 6 cycles on this protocol. Again, the primary endpoint was to see what is the MRD negativity rate after a total of up to 8 cycles, and this is in the absence of a bone marrow transplant. The primary endpoint for the study, as I mentioned, was to look at MRD negativity after a total of up to 8 cycles of weekly wKRd-D dara, and this is in the absence of a bone marrow transplant. We used the traditional ways of assessing clinical responses with the IMWG criteria, and that includes also the bone marrow assessment for MRD negativity. We used in this study parallel 10-color single-tube flow cytometry, as well as VDJ sequencing to determine MRD negativity. For practical purposes, the study used the flow cytometry for all the patients because that was done for each and every patient. The sequencing was done for the majority of the patients. The results were very consistent. They were identical for the 2 assays. And we have actually just published a paper in another journal, just came out some weeks ago online, where we evaluated several hundred patients at our center with the 2 methods that I'm referring to, and we show extremely high concordance. There is a 99% concordance between the 2 methods in our hands. The key results of this study, again, based on the primary endpoint being MRD negativity after up to 8 cycles, are quite striking. I would say these are unprecedented results. We show that 71% of the patients achieve MRD negativity after up to 8 cycles of weekly wKRd-D dara. And I think if we look at other studies that have recently been presented and published, we see that these results are very, very strong. So for example, the Griffin study that was recently published in the Blood Journal, after 6 cycles of the wKRd-D regimen and a bone marrow transplant, they achieved in the intention to treat analysis 20% MRD negativity set to 10 to minus 5 negativity. In the other arm of the Griffin study, they gave 6 cycles of wKRd-D daratumumab and a bone marrow transplant. And in the intention to treat analysis, they achieved MRD negativity in 51% of the patients. So wKRd-D dara, 6 cycles and transplant, 51%. In the current study, single arm, it's not the same study, so patients may not be the same, and there are a lot of other differences, I'm sure. But nevertheless, after 8 cycles of wKRd-D daratumumab, without a bone marrow transplant, we found 71% MRD negativity set to 10 to minus 5, same. So I think these results are very, very strong. There are additional presentations at this ASH that highlight on the importance of MRD in the newly diagnosed setting. And to me, the IFM 2009 follow-up study that will be presented as an oral showing at 8 years of follow-up, MRD negativity is the strongest predictor of outcome. And they also show and they discuss that there is no survival benefit of transplant in the upfront setting. And in the conclusion of that abstract, the authors say that with 4 drug combinations being implemented in the future, most likely very many patients could achieve MRD negativity, and the utility of transplant could move to a delayed use of melphalan and stem cells if needed. And I think that is probably where the field will be going. It is always hard to predict the future, and we have many times been wrong. But I think when it comes to the multiple myeloma field in the newly diagnosed setting, looking at powerful combinations and MRD assessment, I think there are not so many studies. So if we were to guess where the field is going, it's most likely going to be somewhere in the direction where the majority of the studies are. So if I just look and see the IFM 2009 study with 8 years of follow-up presented at ASH 2020, showing that there is no added benefit of transplant if you use combination therapy that's effective. That's what they show, VOD plus minus transplant, no survival difference. And then you look and see the 4-drug combination achieving very high rates of MRD negativity. You can do the VOD DARA with transplant with 51%, or KOD DARA without transplant, we showed 71%. I think it's very likely that patients could be treated with these powerful combinations, achieving MRD negativity, and collect and store the stem cells and have them as a backup. Still, the transplant would be a valid option if you don't have access to all these drugs. There are many countries where you don't have access. Transplant still is the most powerful option. So therefore, that should be used. And for patients who don't have the great outcome with these new drugs, I think transplant still plays a major role. But I think the big shift, will be the implementation of MRD testing and the option of delayed transplant for patients who have a great response to the new drugs. That's what I think. And I think maybe additional antibodies could continue to stir up and maybe get rid of some of the other drugs. Maybe it's going to be only antibodies in the future. We'll see.